Uh, so welcome to the Peer Medics Zoom to find the second session on vascular surgery. So we'll cover through main information on carotid disease, chronic limb ischemia, including critical limb ischemia, the acute limb ischemia, and then the lower limb ulcers, the venous, the arterial, and neuropathic. So in terms of the carotid artery disease, it refers to the narrowing and occlusion of either or both the common and internal carotid arteries by atherosclerotic plaques that are formed. It's mostly asymptomatic, but it has major complications in that it causes 10 to 15% of ischemic strokes. So what is the pathophysiology of the carotid artery disease? It's in essence the pathophysiology of atherosclerosis formation. So you get the cascade of endothelial dysfunction and damage triggered by the risk factors like hyperglycemia and hypertension. That leads to the inflammatory response where monocytes migrate into the artery wall from the blood and then undergo differentiation to become macrophages that eat oxidized LDL, which makes them leads them to form the foam cells, which causes the fatty streaks. There's then buildup of the lipid core before some smooth muscle proliferation and migration from the tunica media into the tunica intima, which forms the fibrous capsule covering the fatty plaque. The turbulence in the flow of blood in the bifurcation of the carotid arteries is what leads to the predisposition of the atherosclerosis, as it leads to more endothelial damage at that specific area. So how do we classify carotid artery disease? It's classified on depending on the radiological findings, on the degree of stenosis. So having mild disease is less than 50% diameter reduction of the carotid arteries, 50 to 69% reduction, that's moderate, and severe is 70 to 99% diameter reduction, and total occlusion is a 100% diameter reduction. So risk factors, the major risk factors like other vascular diseases, they include old age, so anything greater than 65, smoking, hypertension, high cholesterol, hypercholesterolemia, obesity, diabetes, and a history of cardiovascular disease and family history as well. So like I said, in terms of signs and symptoms, it's usually asymptomatic because the vertebral arteries and the internal carotid arteries on the other side of the supply the circle of Willis. So it's only when you get bilateral severe stenosis, then you can become symptomatic, causing stuff like headaches, dizziness, confusion, aphasias, or problems with memory. But you can also get the focal neurological deficits due to TIA or stroke, which can lead to the ipsilateral transient visual loss, the contralateral weakness or sensory changes, or the disturbances in the limbs or face, or you get the collapse or the dysphasia, the aphasia, or the speech apraxia. But mostly on examination, if you're lucky, you can, in carotid artery disease, you can hear the carotid bruise. In terms of investigations, if there's a stroke or TIA signs and symptoms, then you do the stroke investigations, which include urgent non-contrast CT, heads, bloods, in terms of full blood count using these clottings, lipid profiles, and glucose, to investigate the cause and rule out differentials, ECG check for atrial fibrillation. But specifically for carotid artery disease, you do duplex ultrasound scan initially to visualize the stenosis and the atheroma buildup. CT angiography or MR angiography can then be done before the surgery in the like carotid endarterectomy, as they're more accurate assessment. Moving on to the management. So in terms of medical management, it involves controlling the blood pressure with antihypertensives, starting statin treatment to lower the hypercholesterolemia, and as cover as well, and then antiplatelet therapy with either low dose aspirin or clopidogrel. In terms of the surgical management, like I said, you could do carotid endarterectomy, which is removal of the stenosis and the aceroma made by from the fatty deposits and blood clots from inside the carotid artery wall. So all patients who were symptomatic with carotid stenosis of 50 to 99%, who then go on and have a TIA or stroke that is non-disabling, are referred for it. Just moving on and giving a case, just a flavor of what something can present as. So you have a case of a 70-year-old female patient who presented to her GP with a right leg pain on exertion for the past 12 months. She feels her right calf is cramping when walking, usually more than about 300 yards. The pain goes away when she stops walking and rests. She has a past medical history of diabetes and hypertension, and she's a smoker. Main differential, if you would like to pop that in the chat. So 2 answers have come through, DVT and PVD. So both work, but it's more of a PVD picture because of the distance gets better when she rests, and the time frame. So yeah, we'll move on. So PVD, and you can get it in stages. So in stage 1, your patients are asymptomatic. Then when you move on to stage 2, it becomes an intermittent claudication, where you get exercise induces cramp pains and tightness in the legs, which are relieved by rest. So yeah, pain felt in the muscle on exercise that disappears on rest, and the area of the pain that gives you a clue on where the stenosis is in terms of blood vessels. In stage 3, so anything past stage 2 is chronic limb ischemia. And stage 3 is defined as ischemic rest pain. And finally, stage 4 is you get ulceration or gangrene that appears in the limb. In stages, if you hit stages 3 and 4, that's classed as critical limb ischemia. So what is chronic limb ischemia? So it's the narrowing of the arteries, which causes arterial insufficiency and reduced blood flow to the limbs. And it's, like I said, the symptomatic peripheral arterial disease. It's most likely happens due atherosclerosis, and you're at increased risk and becomes more common as you increase in age. About 4% have a 1-year mortality on average when they hit intermittent claudication. So what are the risk factors? It's the same: increasing age, hypertension, the diabetes, the smoking, the hyperlipidemia, the obesity, and the physical inactivity, and a family history. So what is critical limb ischemia? I said that's the final stages of chronic limb ischemia. So it's defined as having greater than 2 weeks of at rest ischemic pain that needs opiate analgesia, to support it, or having an ABPI less than 0.5, or the presence of ulcers or gangrene. And you can see that the 1-year mortality is jumped from 4 to 12 if you hit critical limb ischemia. So you get higher risk of death. So what are the signs that makes you suspicious of critical limb ischemia? You get hair loss, pale limbs, cold limbs, weak or absent pulses, the thickened nails, or ulcers and gangrene. So one test that's done on examination to assess for arterial insufficiency is a Berger's test. So you raise the patient's legs while they lie flat until the limb becomes pale. Then you bring the leg down and observe that the color goes back normal, and then it becomes red because of the hyperuremia that's happened. And the Berger's angle is the angle that the leg became pale at. So severe ischemia is when that angle goes below 20 degrees. Chronic limb ischemia is a clinical diagnosis, but in terms of investigations, you start off usually with an ankle brachial pressure index, so to confirm diagnosis and rate the severity of the condition, and it can predict what symptoms that the patient is having. It's basically the ratio of the blood pressure at the ankle to the blood pressure in the upper arm. So you take the blood pressure in the leg and divide it by the blood pressure in the arms. The lower blood pressure in the legs comparison to that of the arms suggests that you get blocked arteries due to peripheral artery disease. So the lower the ABPI, the worse the disease. In terms of classifying it, if you get a value greater than 1.2, that's usually false reading due to calcified vessels. Usually happens in diabetes. Value greater than 0.9, that's normal. 0.8 to 0.9, that's mild disease. 0.5 to 0.8, that's moderate disease. And then anything less than 0.5, that's severe. After ABPI, you do duplex ultrasound, and that's the first line investigations to assess the anatomical location of the occlusion and assess the severity. Then CT angiography or MR angiography can be used further down the line if you're planning surgery, to consider the suitability for and planning the surgery, because they're more accurate. You can also assess and investigate the cause of the PVD. So you can do a cardiovascular risk assessment. So that includes blood pressure, the blood glucose, the lipid profile, and ECG. And if the patient is less than 50 years and you can't really see a clear cause, thrombophilia screen and homocysteine levels can be checked as well. Like I said, ABPI can be used to know what symptom patient can be presenting. So usually if the value is normal, 1, you get no symptoms. 0.6 to 0.9, you get the intermittent claudication. You would expect that. Between 0.3 and 0.6, rest pain, and anything less than 0.3, you get the ulcers and the gangrene. So in terms of management of chronic limb ischemia, just like the others, medical and surgical. In terms of medical, it starts off with assessing the cardiovascular risk factors and modifying them. So we start off with lifestyle changes and advice like exercise, weight loss, smoking cessation. You start statins, usually atorvastatin 80 milligrams once daily, antiplatelet therapy, most likely to be clopidogrel 75 milligrams once daily. You'll try to optimize the blood pressure and diabetes control, so your antihypertensive and diabetic meds. And then the supervised exercise program. So that's the first line therapy for any patients that has critical limb ischemia, because it improves the walking distance and the claudication distance in comparison of just giving them exercise to do at home. Being supervised improves it, improved outcomes. Peripheral vasodilators can also be used to manage the symptoms that the patients are getting. In terms of the surgical management, patients who have supervised exercise and it has failed to improve their symptoms, and they have tried the risk factor modifications, but haven't helped, they can be offered the surgical intervention according to the NICE guidelines if it is suitable. So patients with critical limb ischemia are urgently referred for surgical intervention, irrespective. The two main surgical options for revascularization are the angioplasty, with or without stenting, and a bypass grafting. Usually bypass grafting is used in the younger patients or those that have a widespread disease. Amputations is a last resort. So they're usually done for the patients who are unsuitable for the revascularization, or they have had gangrene that is leading to sepsis or incurable symptoms, then amputation is the option. In terms of differential diagnoses for clinic limb, you can get the acute limb ischemia, which we'll go through shortly, which is usually a short history and less than 14 days, and spinal stenosis, where you get the back pain radiating down the lateral aspect of the leg, but that pain gets better by sitting and pain is on an initial movement. So moving on to acute limb ischemia. It's defined as the sudden decrease in limb perfusion that causes a threat to the limb viability. So causes of acute limb ischemia can be broken down into three main groups. The most common cause is the embolization, where the thrombus from a proximal source dislodges and travels distally to occlude the artery. The source of the embolus could be due to AF, post-MI, abdominal aortic aneurysm, or from a prosthetic heart valve. Second group is thrombosis in situ, where the aceromous plaque in the artery ruptures, leading to the hypercoagulability and then the clot formation. So it's acute or acute on chronic, basically. And the least common cause is vessel injury, so due to trauma or due to iatrogenic cause. One of the traumas that could happen that could cause it is like a compartment syndrome as well. 20% in acute limb ischemia, you can see that there's even higher risk of death, 20% 1-year mortality. So signs and symptoms of acute limb ischemia, the 6 Ps. So pale, pulseless, painful, paralyzed, paresthetic, and piercingly cold. You can see from the picture a lot of just portraying that. So what investigations are done in acute limb ischemia? Bloods, usually most important, serum lactate to assess for the level of the ischemia. And then the rest, the normal stuff, full blood count, T's and E's, LFTs, glucose, and lipid. Initially, the investigations is for all patients is a bedside Doppler ultrasound scan of both limbs, followed by a consideration of a CT angiography. In patients that are deemed the limbs as salvageable, a CT arteriogram is used to get more information in terms of the anatomy and where an operation can be done. And in terms of looking for the causes of the acute limb ischemia, an ECG looking for AF can be done. So the management of acute limb ischemia, yes, surgical. It's a surgical emergency. You get irreversible tissue damage within 6 hours if you don't intervene early. So it's essential that you get a vascular referral as soon as possible and try and start management. Analgesia should be given to support the patient, as well as high flow oxygen, and you make sure that you get adequate IV access, and heparin is started. So in terms of the conservative management, you give prolonged courses of heparin, and you monitor APPT, and you do clinical reviews. And then you get surgical intervention if there isn't any improvement in the conservative management. And then the surgical management that can be done depends on the cause. If the cause is embolic, you can do an embolectomy or thrombolysis or a bypass surgery. If it's a thrombotic disease, then you can do thrombolysis, bypass, and angioplasty. And if the limbs aren't shelvable, you can either do amputation or palliative care, depending on the patient. Moving on to the last topic, lower limb ulcers. So ulcers are breaks in the skin or the mucous membrane. You can get many causes for lower limb ulcers. It could be arterial, venous, neuropathic, so diabetic related neuropathy. It can be due to infection, trauma, vasculitis, malignancy, and most importantly, 10% of ulcers are mixed venous and arterial. So it can be mixed different types. So it's important to keep that in mind. So how can you tell arterial ulcers? So they're usually small and painful, usually painful when they're elevated. They appear punched out, deep, and have irregular shape. They present over the pressure points like back of the heel or the toe, so or the plantar aspects of the big toe, or the lateral malleolus in the ankle. You can get gangrene and necrotic tissue can be present, and it's important to check ABPI because you cannot use compression bandaging in arterial ulcers because it's associated arterial ulcers. You get it mostly because of peripheral arterial disease, so you don't want to compress the blood flow anymore. So you can get gold feet, the absent pulses, the reduced APPI from the peripheral arterial disease as signs with arterial ulcers. The venous ulcers, so they're a consequence of the venous insufficiency. Some signs that of venous insufficiency are like edema, brown pigmentation, the lipodermatosclerosis, and the eczema. Venous ulcers are the most common leg ulcer type to see in practice. They're most likely classically found over the medial malleolus and the, or medial calf, the gaiter area. They have irregular borders with a granulating base and appear shallow. They're usually painless except if they become infected. In terms of management, it's a 4-layer compression banding once you've excluded, like I said, the arterial disease. If that doesn't work, skin grafting is done if the ulcer is greater than 10 centimeters or it fails to heal within about 12 weeks. Neuropathic ulcers, they're found in the pressure areas and usually are painless as well. Found in the plantar surface of the metatarsal head or the plantar surface of the helix. They're deep and can be surrounded by callus. Usually the rest of the foot is warm with reduced sensation, and it's associated with diabetes, and it most commonly leads to the amputation in diabetic patients. Cushioned shoes can be used to reduce the callus formation as part of management to try as much as possible not to get the neuropathic ulcers. Just finishing off, just if you guess the ulcers from the picture A, B, and C, and just put them on the chat. Yeah, seems everyone has got them right. Yeah, the first one is a venous ulcer. The second one, arterial, because you can see the punched out, they're deep, they're irregular shape. And then the neuropathic ulcer in the pressure area, or the plantar surfaces. So yeah, that's all done. So what resources I've used? Used TSME surgery, the Oxford Handbook of Clinical Surgery, the BMJ, best practice, past medicine, and patient.info. Really recommend them for everything. They're really good. So thank you for listening.